Welcome to this episode of AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Tina Pennington, and she is a clinical services manager of the Power team for UAMS. Tina, thank you so much for joining me.
You are welcome. Thank you for inviting me, Robin.
Of course. So tell me a little bit about the services that your team provides.
Okay, I am the clinical, as you pointed out, the clinical services manager for the Power team. And Power stands for Perinatal Outcomes Work Group through Education and Research. So we are located at UAMS. We are under the umbrella of the Institute of Digital Health and Innovation's High Risk Pregnancy Program. So we're kind of what I call the boots on the ground for getting the work done. There's a lot of UAMS is a fabulous place with lots of great thinkers, and that thinking disseminates down to us who gets it out to those who need it.
And tell me about those educational offerings.
So our educational offerings, the main ones that we do staff educations for there are currently 37 delivering facilities in Arkansas, and a lot of those have very low volume where they cannot afford to have that specialized maternal infant education and the resources. So we are actually provided by Medicaid and through contracts to provide these services for free to the hospitals that need them. So some of the things that we do are electronic fetal monitoring. Everyone knows when you go in, you have a baby, they strap you up to the little monitor there. Well, that nurse needs to be able to interpret what that machine is telling her. Is that baby's heart rate appropriate? Is mother's heart rate, everything kind of acting like it's supposed to? And that becomes a very big legal issue, because that's exactly, if something goes to court, they're going to look at that strip. And you want that nurse to be able to properly, interpret that strip. We also teach, I'm a neonatal expert. I've spent 18 years in the NICU here. And so I think I'm all things baby. So I teach neonatal resuscitation for those babies that come out and kind of look at you like, what do I do now? And I teach another program called Stable, which is an extension of NRP, which is great for these outerlying hospitals. We offer OB simulation, emergency simulation. In fact, I'm going to a facility this evening to do that. We have, her name is Noelle, and she's a life-size high fidelity mannequin who actually gives birth, can speak 7 languages, and does cocaine in the evening. She can give you all kinds of disorders, but we can practice shoulder dystocia. She can hemorrhage. She can have seizures, all kinds of different practices. So the nurses get education when it's safe, when the patient is not at risk for it happening. And we do it in their facility. That way they know where all the equipment is and, how to properly respond. And our newest is what we call obstetrical patient safety. It's actually a national program that we have purchased. And it's a day-long kind of in-depth emergency preparation. They play games and do all kinds of different things, and involves the emergency department as well, because a lot of times that's where that lady's going to come in, and you want to be able to start her treatment really quickly. And we have all kinds of other little great webinars and meetings and social platforms and things. So I could go on all day about what we offer as far as outreach education.
So tell me about the Birth Equity Focus Group, and what is that?
One of the things let me give you a background and statistics for the state of Arkansas. So, excuse me, I'm going to have to read these. The national maternity mortality rate for 2021 for the United States was 23.5. Arkansas, it was 43.5. That is a difference of 46%. You are 46% more likely to die in childbirth at Arkansas than the national average. And that's a scary, scary statistic. It really is. And it's twice that if you are African American. So the Birth Equity Project was put into place to try to figure out, look at different reasons of why there's such that discrepancy, why that is such an issue. Now, they say it's a lot of things. National research has shown it's a lot of things like respectful care, access to providers, access to services, different things. Well, we necessarily can't do access to providers or add services, but we can definitely educate facilities on how to be more respectful, and how to be more equitable when they deliver care. So we have a task force and a couple of pilot sites around the state that we are kind of focusing in on. Let's figure out why these things are happening and why people are uncomfortable going into the healthcare setting, and how can we help them.
Well, tell me a little bit about the Arkansas Perinatal Quality Collaborative.
Up until last year, Arkansas was one of I think it's 2 to 4 states that had not been able to join the AIM program, which is the Alliance on Innovation in Maternity Care. That's a very important kind of a data resource where they talk a lot about safety practices and research behind it and things like that. Well, since then, we have gotten our maternal mortality review committee, and we have now formed our Arkansas Perinatal Quality Collaborative, all of which allowed us to get AIM. So we're very excited there. But what it is we got 33 of the 37 hospitals in Arkansas to join, which is great. I mean, that's really good. And we have a couple that are still kind of deciding. And that's really great because most, when they first start a program, don't get that percentage. We're talking like almost 90% of the hospitals in the state are doing it. So that's great. And what we're going to be doing is kind of starting it as kind of a research project, but it's called a collaborative because we're coming together to direct a specific problem. And several of the other states around us do different. We've already kind of been doing some work on safety bundles, such as postpartum hemorrhage and hypertensive emergencies. Now we're going to bring in what's called the safe reduction of the primary cesarean section.
So what is an Alliance Innovative Maternity Care?
So it is a national maternal safety quality improvement initiative, and it actually comes through ACOG, which is the American College of Obstetricians and Gynecologists. So it's the physicians saying this is what needs to be done, and it's A1, which is the nurses' equivalent of that, March of Dimes, several other of these widely recognized facilities and companies are also involved with it. And what they've done is kind of looked at every situation, all these different situations that happen or can happen during delivery, and they release safety information on it. What can we do to make this safer? And so their big thing is a safety bundle. And that is when you have a group of policies and procedures that every time you're needed, you do them together, and they make for better outcomes. And so that's kind of this. So the prevention of the safe reduction of the primary C-section is considered an AIM safety bundle. And that just makes you and a lot of times if you get used to it and you run the drills and things, if the hemorrhage shows up, you're ready for it. So there's the 5 R's of any of their safety bundles. I love that they do the 5 R's. You have readiness. Do you have everything in your facility to accommodate it? Where's the equipment? Where's the policies? Who do I call? Everything has been thought ahead. Recognition. What are your trigger points? Okay, her blood pressure is 160/90. Or 180/90. To you and I, if we were to take our blood pressure, that wouldn't be that's a little high, but to a pregnant female, you are imminently could end up with seizures, go into an eclamptic seizure. The threshold is much lower. So recognize what the trigger is and be ready to respond to it. And then the recording and systems learning is where you go back and look at that event. What did we do right? What are our, opportunities of improvement? What do we learn from it? So it doesn't happen again. And then the 5, they've just added the respectful and equitable care portion to each of those 2. But those are, when you look at it that very organized manner, it's much easier for the patient to deal, or the nurse to deal with what's going on, instead of sitting there thinking, okay, is Dr. Smith on today? He likes to do it this way. Is Dr. Jones on? He likes to do it that way. And Dr. Smith and Jones can do what they want to do in a normal situation, but in an emergency, you need to come together and pick a plan. So that is kind of what we've been doing it for several years now, kind of informally. The Perinatal Quality Collaborative is making it formal. We've got contracts for data and different things like that. So it's a very formal process, and we're going to, I think, have some wonderful studies come out of that.
And would these all be considered interventions that nurses can do?
Yes, definitely. Nurses can do. In fact, most of these are nurse driven. That the nurse is the one who can start the ball rolling, so to say. And a lot of times, the great thing about having this is you can be well into it before the doctor, while you're waiting to notify the doctor or while you're waiting for the doctor to come in. These things can be happening.
And how are you changing the outcomes and culture environment of giving birth in Arkansas?
That has been a fun process. It really has been. I think a lot of times, especially in the communities, birth is supposed to be a happy experience. My first son was born in a small hospital. It was fun. All the friends from church came over after and stuff, and it was a happy event. But when a serious situation happens, it can go downhill very quickly. And so that's our focus, is to make sure that the nurses, the doctors, even the lady answering the phone at the desk has her call tree that she can start, are involved and can make for much, much better outcomes for these patients.
And what can we do to encourage this type of change?
Community awareness is always really important. One thing that we are doing with the Perinatal Quality Collaborative is, in exchange for them doing the data collection and doing all this, they're going to get the title of birth-friendly hospital. So they can use that for community marketing. Hey, we're birth friendly, even though we're small and we don't do a high volume of delivery. We have in our arsenal the same things that they're doing, at the regional and the state facilities. We're doing the same things. So we would like to think that we're a safe facility to give birth to a baby.
And studies show that maternal deserts are a problem everywhere. How is this specifically in Arkansas?
Okay, so maternity desert, that's kind of a term that March of Dimes has kind of picked up on, and they define that as a county without a hospital that is devoted to, or a birthing center offering maternity care. So Arkansas has 75 counties. Of those, I believe, let's see, how many was it? It was 46.7% of the counties in Arkansas, and I believe that was 35 counties are considered maternity care deserts. They do not have services, maternity care or birthing center services provided. And it also goes into how far they have to travel, and and if there is available resources such as insurance coverage, things like that. There's large counties where where the employers don't offer maternity care. That's a big issue also. But this was actually in 2020 is when the March of Dimes put out this study. In 2022, we lost 2 more facilities. We're now down to 37. They had it at 39 facilities. So we lost 2 counties. Phillips County and Columbia County lost their maternity care. So that's now 49% of counties in Arkansas are considered maternity care deserts. There's not, and so these ladies sometimes have to travel anywhere from 30 minutes to an hour to an hour and a half to deliver a baby, and that's not safe. Because often you will get into traffic accidents. You have things like that, and just that is a huge access to care issue that we need to do some research on. We need to see what we can do. Of course, that's more providers, that's more telehealth, sites, just different things like that we're going to really need to tackle, because Arkansas, that is a big issue in Arkansas.
Well, Tina, before we close, I want to know about the Power team and what you ask healthcare providers and community partners to do. What can they do to learn more about your program and get this education materials into their offices and into their patients? That
is an important thing. Is we do a lot of as far as the Power team and what we do, a lot of ours is done at the staff level of the hospital, where a lot of the important community public health information, key trigger points, we do a lot with the post-birth warning signs, what to do when mother goes home. These are things that needs to be taught beforehand and gotten into the physician's office. I know you guys there at AFMC I've worked with your team there, and they're really good about, they will do kind of the office counterpoint to a lot of what we do in the hospital. So I've worked with your team quite a bit with that. And they've done some stuff with us. But the UAMS website, uams.edu, we are on the website there. If they want information, they are welcome to reach out to me at Pennington. You can put this in the credits, Pennington Tina C at uams.edu. They are welcome to contact me for any further information about if they have any. Again, I love to do the research. I love to answer the questions. And in fact, I'm doing, like I said, we're doing OB-SIM tonight. I'm doing a talk on Friday. So we've got lots of educational opportunities out there.
Well, Tina, it's a pleasure to talk to you today. I've learned so much, and I think you are doing really incredible work for the state of Arkansas. So thank you.
Thank you. You're welcome. Thanks for having me, Robin.
And that's it for this edition of AFMC TV. I'm Robin Ledbetter. Thanks for watching, and have a great day.